Welcome to the Phoenix Insider, your all-access pass to the stories shaping the future of mobility and health equity. Each episode, we dive into real-world challenges and innovative solutions that impact transportation access in communities across the country. From candid conversations with industry leaders to first-hand accounts from the individuals we serve, the Phoenix Insider gives you a front-row seat as we work toward creating mobility solutions for the health and well-being of every person in every community. Join us on this journey as we pave the way for a more equitable and connected world.
Welcome to the show, everyone. I am absolutely thrilled today to have Ashley Hutto with us here on the Phoenix Insider. Welcome to the show, Ashley.
Thanks. I'm excited to be here.
So a little about Ashley before we dive in. She is a fierce community advocate and activator. She is currently the West Dallas Multipurpose Center manager, where she works with many community-based organizations, providing just a complete portfolio of programs and services to meet the needs of local residents. She brings with a wealth of expertise to the conversation today as the operations manager for Baylor Scott and White Health and Wellness Center at the Juanita J. Kraft Recreation Center and the Dallas director of Texas A&M Institute for Obesity Research and Program Evaluation. Ashley is also the esteemed author of the Texas Department of Health and Human Services Certified Community Health Worker Training Center, which is so important about the work that we're doing, and we'll get into that. And in addition to that, she facilitated the development and authored a collaborative action plan charting the course, providing a pathway for Dallas eliminating childhood obesity in the community. And my personal favorite, Ashley is also a current board member at Phoenix. So thank you so much for your time, Ashley. I know you have 9 million things you could be doing right now, and thank you for spending some time with us.
Thank you for having me. I'm super excited. I sound really good on paper, so I hope I live up.
So as we get started, I always like to kick it off. Tell us a little about where did you grow up, first job, what was your first, how did you get around in high school? Like, tell us just about Ashley before we dig into it.
So my stepdad was a district manager for Bristol Myers before they merged with Squibb. And so we moved about every 4 years. So I was born in Baton Rouge, Louisiana. I went to elementary school in New Orleans. Then we moved to Columbia, Maryland for junior high. So that was a little bit of a culture shock because we went from New Orleans to the first master planned community in the country. And then we went to Oklahoma. And so I went to high school in Edmond, Oklahoma. And I went back to Houston where my grandparents were. And if you ask me what is home, I usually say Houston because that was sort of our base. But went back to Houston for college and have now been in Dallas about 25 years. My experience with transportation over the course of all that time has really been kind of interesting insofar as we had 2 cars, so we, somebody drove us around until we were old enough, and then we had our own cars. But the window of time when we lived in Columbia, Maryland, which I mentioned was one of the first master plan communities in the country, they had it was kind of a closed community insofar as that. And they had a little bus that ran around town, our little suburb. And every household, like a country club membership or whatever, part of your HOA dues went towards being a member of the community. And all of us got, once you had to at least be 12, which I happened to be. And you got a little card and you could ride the bus. It got you into the roller rink, the skate rink, all of the kind of amenities of the community. Your little membership card got you into. And so as a middle school youth, I had a very unique and, very privileged experience because we could go to the mall, we could go to the roller rink or the ice rink or go get a hamburger or whatever. Even though none of us could drive, we could all get on the little bus because we all had the little membership card in common. And all that to say, I never really realized anybody had any trouble getting from one place to another until I was an adult and I was working in communities where transportation was a barrier for them. It never presented itself as an issue to me because I had the advantage of both private and public transportation, just in a very, very controlled, very suburban environment. I mean, I'm a little bit older, so, you can tell it was back in the day when this little bus ran around. But it made a huge difference in our independence and our agency as children because we were able, to have a level of autonomy that children don't have today.
It's interesting you bring that up, Ashley, because I think a lot of times when we talk to people, especially in like the engineering space, intelligent transportation engineering, they're so focused on how the roads are built, how the bridges are built, how the sensors function. This conversation, there's millions of people who cannot even access those roads or those highways, or they do not live anywhere near a bus stop, and that's not a reality. And I think it's like if it's not in your frame of reference, it doesn't rise to that level. And I think in philanthropy, we very rarely hear just a transportation focus. I mean, would you say that's fair? Where if you didn't...
I agree. I mean, we've been talking about the social determinants of health now for, 10, 15 years, but transportation never had its own piece of the pie in that. But I think that more and more as of late, it has been elevated because, in my opinion, one of the reasons why it's getting more attention is because people, executives, C-suite leaders are beginning to notice that transportation is a means to an end for community to engage with them. And so I think there's a business case around transportation access. But I also think there is a social service-based conversation to have around transportation. And I don't think previously it was happening in either entity. Yeah. It was getting lumped into something else.
Yeah. And I think that the business perspective of that, what's the ROI, is definitely a driver. It's like if you can't get to a $3,000 chemotherapy appointment and a $9 or $19, taxi or Uber ride prevented you from that, that's lost revenue every day of the week. And
Absolutely.
And so not only is it good for public health and is it the right thing to do, but it also is good business sense. So, okay. So Ashley, only child, do you have brothers and sisters? Kind of.
Sure. Yeah. We have a half brother and sister, and we're 13 years apart.
Okay.
And I will tell you, I was not impressed when this baby came on the scene. I was like, okay, it's been fun. See ya. But I was a middle schooler at that point. And so I was raised largely. I was an only child to my mother and my biological father. I didn't have any younger siblings with my mother and my stepfather. And I'm an only child with my biological dad. And then I'm the first grandchild that my mother's parents had on their side of the family. So I did pretty well for myself growing up.
The first grandchild is a special place in Grandma and Grandpa's hearts, to say the least.
Absolutely. And I was very fortunate that at the time my mother and I, we lived with my grandparents until I was about 8 when she remarried.
Okay.
So not only was I the first grandchild, I was like their 6th child. And the opportunity for me is they were both at the age, my grandmother never worked, but my grandfather was semi-retired. And so they had lots of time to invest in me.
Yeah.
And so I had a very close relationship with them. And when my interesting, I guess, relevant to transportation, my grandmother was fiercely protective of her ability to drive. She passed away at 94. And when she passed away, she still had an active driver's license and a car of her own. Now, she let me drive most of the time, but she had to renew when she was 92 and was super worried they weren't going to let her have her license, because for her, it was the definition of independence.
Mm-hmm.
You know, and so I can remember that, the whole, and like I said, she really hardly ever drove, but she knew she could.
Yep.
And that made a difference for her.
Yeah.
That made a huge difference for her.
Yeah, there is very few things that I think folks hold dearly at that point than that sense of independence of, if I need to go, I can. I don't necessarily
Absolutely.
have to, but I know
Right.
I have the option. And when folks see that slip away, that is so tough. And in many cases, I remember when we were working with ARP, they said that's one of the hardest conversations folks have to have is, mom or dad, I don't think it's safe for you to drive anymore. And the tension and the anger and all of that. I mean, it's intense. I had a great grandfather that lived to be 104, and he had his driver's license till he was 98.
Yes.
And he just about literally couldn't see it all when finally he accepted this was the path that was safe and best. But you weren't gonna take it away from him. You weren't gonna trick him. It was the path. So,
and that was my grandmother too.
Yeah. Yeah. Because he had his faculties till the very end. Like, he would call and say, I grew up on a farm, right? How much rain did you get down there? And I saw you had this many hundreds in this place and this many hundreds in this place. I remember he would call and I'd be like, you're 102. Why do you care?
Why are you worried about rain? Right.
So, all right. So turning the page. So on the Phoenix board and in your work of public health and advocacy, what aspect of Phoenix's mission is most important to you personally? Knowing all this space and also your journey, kind of what resonates most from your perspective?
I feel like one of the things that I bring to the table for Phoenix that supports the mission is that perspective, that public health perspective, that social service orientation and interest in being able to address transportation as a social determinant of health, as a social determinant of wealth. I think it more and more it's beginning to have an impact in the conversations that people are having about how do we build wealth in the community.
Absolutely.
And the relationship between, trying to move the needle in that space and the need for transportation. So I think the experiences that I bring to the table are of benefit to the mission. That being said, I think the piece of the mission that resonates the most with me is really our commitment to mobility for all, and being able to look at mobility solutions kind of across a continuum. Because what's good in one community may or may not work in another community. 100%. I understand everybody in New York uses public transportation. In Dallas, we need our car, and so I think it's that piece of the mission that I'm most committed to, perhaps because that's the area that I function in. But I really think that the impact and the agency, the commitment to agency that the Phoenix mission delivers is most exciting for me. Is the crux of my experience, but is also the area that I have the most interest in.
And that focus where it's not just about a ride, it's about the outcome that happens from the ride. And we're so thankful and appreciative, Ashley, for your perspective and your patience as you're like, oh, for the love of Pete, I'm gonna lose it if I have to hear one more rant about charging stations. Like, God bless.
And and frankly, I will tell you that I kind of filter out when we get to the kind of the engineering discussions about the nuts and bolts and mechanics, and I'm like, is this going to get somebody to the doctor? Will this thing and this thing both get you to the doctor? Okay, well, let's use both then.
Yeah, amen.
So I think that's my space.
Yeah. Well, and I think one of the things that we're really digging into recently is the importance of fatherhood. And when we talk about infant and perinatal health, the importance of the father. And I think that is one of those things where when we talk about building wealth and we talk about support, alongside of that, when we've done these perinatal health and infant mortality programs to provide mobility, one of the first needs that comes up from the mothers is, I need to get to work. And then, well, the wallet or the funding is not enough for 2 trips a day, 5 to 6 days a week. And how do we support? And then when you add the father component of it, how do we support the father to support the family? And that whole equation is such an important dimension to public health that really doesn't get discussed enough, of how important economic mobility is to health in general and to sustainability as a family. So thank you for your patience and your guidance, Ashley. And I'm 100% just thrilled we are in lockstep on this. It's not,
yes,
I don't
ma'am.
get up in the morning because I like charging infrastructure. I get up in the morning because we're right. Difference. And not that charging stations don't, but it's, Right. All right. So you have had an impressive career in community health and advocacy. Can you share maybe a little bit more? I know you talked about it kind of at a high level, how your experiences shape that understanding. Is there a story that comes to mind, or a certain point where you really saw how this cascading effect happened in the social determinants of health?
Sure. It was actually relatively recent, probably dating back about 10 years ago. I was at Baylor Scott and White, and one of the things that I was charged with was an understanding of missed appointments. And it became, and again, that's in the business case space of things. They book their appointments, they need them to show up for their appointments. And then we added in the Community Health Training Institute. And so then there was also a health outcome that we were looking at, was, did community health workers move the needle on, at that time we were looking at diabetes, bringing diabetes into control range. So it's interesting. I also landed on a committee that was recently formed, or had been recently formed, in South Dallas, the South Dallas Transportation Initiative. And I think I probably just drew the short stick to get on it, because I don't think anybody perceived at that time that transportation was a thing, really, to anything that we were already doing. But it became really, really apparent really, really quickly that one of the things that the essence of the no-show issue could be traced back to transportation almost directly. Because from Baylor's perspective, we were seeing a very high number of community members from South Dallas who are largely under or uninsured, visiting the emergency department at Baylor with uncontrolled chronic conditions. And in our case, we've specialized in diabetes. So we were seeing a lot of people who were way, way out of the control range for diabetes, hitting the emergency departments in acute crisis stages. And so we started looking at it. And, you know, we had lots of spreadsheets and numbers and graphs and things to look at. But I was also the person collecting a lot of this data. And you probably haven't noticed, I'm a little bit chatty. I started talking to these people. And I found out that, well, it was only one bus that they had to take to the emergency department. It was two they had to take to the center. I found out that you could go to the emergency department and get a battery of tests for one-stop shopping, whereas you had to come to the center multiple times to get your this test, that test, and the other thing. And so I started looking at it, and initially I thought, okay, well, what they're telling me is this is a convenience thing. It's more convenient to go to the emergency department than it is to hassle with the clinic. But then we started looking at it really in relation to the community health worker program. And we realized that there was a common denominator there, that the more times they saw their community health worker, the better their outcomes were. The more quickly we get them into control range, the more quickly we got compliance of medication, administration, just really the more quickly everything we were trying to achieve happened when they came to see their CHW more often.
That coaching support.
That coaching was a cornerstone. So then we started trying to understand, well, if it works so well, why are so many people foregoing it? You know, because it's free, so cost isn't a barrier. It's in their community. It's culturally relevant. You know, we had checked all the boxes. And so we were like, well, why wouldn't they come? And that's when we heard for the first time, well, I don't have a way to get there. My auntie's at work. And we were like, what? And then we heard again, well, my daughter can't bring me to class because she's at work. And I can't ride the bus, or I don't have money to ride the bus, or the stop is too far, or whatever the case was with the bus not being able to bring you. At the end of the day, because Dallas is largely a single car community, whoever had this car was kind of the keeper of the interaction of everyone else in the household's ability. And so we started then, I kind of accidentally put the two topics together and realized that maybe they were going to the emergency room, not for convenience, but because Auntie was home with the car and could drop them at the emergency department faster than she could take them to the clinic at 10 a.m.
Right.
And so we started like experimenting with, at the time that, about this time was when Uber came to Dallas. And Uber really wanted to befriend the community. And so they gave us a lot of in-kind contributions of rides and transportation things, opportunities. And so we started piloting around that. And could this get people to things more frequently? All the while I'm sitting on this committee for transportation in the neighborhood, and we're kind of just talking about all different things, but I certainly had not put the two topics together. About that time, I started like adding up that all this stuff had to do with transportation. And we realized that there was a solution in the community, but we couldn't seem to get access to it in South Dallas. And that was the GoLink service, which is our public transportation's answer to Uber.
Yep.
And so with we started having more and more conversations because they had GoLink routes in other parts of the city, not in South Dallas. And our South Dallas people wanted to use public transportation and were more comfortable with it than the Uber. And for a number of reasons, Uber didn't work very well in South Dallas. So we needed this solution that existed in the city already to come to South Dallas. So at that point, we sort of pivoted and became an advocacy committee with the Public Transportation Authority, and worked with city council people and board members. And it took us 3 years to get GoLink into South Dallas. And, and that's a whole different equity and inclusion conversation. But once we brought it to the community, and we managed to get it in a reasonable, when they first gave it to us, it ran from 9 to 4, Monday through Thursday. You
So
imagine what the what the ridership was in the first 2 months.
Very common.
So we finally considered, after we threw a few board members under the bus, they said, oh, all right, well, we'll let you have it from 7 to 7 also, because that's what time the other communities it ran.
Yeah, absolutely.
And so we did that. Well, then we realized, so numbers went up significantly. Well, then we realized that there was another problem. DART had recently converted to a tap card.
Oh, yes.
So we then realized that this whole unbanked problem, community economic wellness, all of that started rolling into our transportation space. And, so then we had to address that. And the only place you could renew your card or add money, green money to your card was at a predatory lender location. So we had to address that.
And everybody who needs to get their bus pass for you.
Right. And so, we have overcome a lot of hiccups that did not necessarily exist in some of the other communities of Dallas relative to this situation. But at the end of the day, if you just boil down the transportation conversation, it very much was both a public health conversation and a business case conversation. Baylor felt warm and fuzzy that people were getting rides. That's wonderful. But at the end of the day, if I could convert people to the clinic instead of the emergency department, that saved them tons of money because this was uninsured care and therefore uncompensated care. And so just by moving the needle in that space, we were able to get some return on that investment to reinvest in the program.
Yeah, I think that's an incredible story that shows the players that need to be at the table, the dynamics that you may need to navigate. For anybody who's listening to this, I was like, we have so many transportation challenges. How do we overcome it? It takes a village. It takes years. There's a lot of red tape. Everybody has to navigate. But you can get there because the value from an equality base, from a social justice perspective, from a healthcare perspective, from a government, a compliance, it's all there. But you got to have a lot of gas in your tank and you got to be motivated to make change. And I think the dynamics that you outline in that, how that lays out was just amazing. For folks who are listening who aren't in the healthcare space, Ashley, do you mind kind of sharing what the different cost drivers are? So if I'm saying, okay, I'm going to the ER, what's that bill for somebody for the same thing they would get in the clinic? Just for folks who are I don't even know what that would look like.
Sure. So you are talking about a 70% price difference of bringing a patient into diabetic control range, which is an A1C under 7.
Mhm.
And so if they're above 7, they're out of control. And so bringing them to 7 or lower can be done with medication and with coaching, nutrition, behavior change. However, that behavior has to be introduced, and the testing to determine if you are within your control has to be done. And then kind of the layer on there, it is a medication managed condition. So you have to be able to get medication from somewhere. So what would happen, or what was happening in the community, was what would cost us $1,000 to address in the clinic, cost us $7,000 to address in the emergency room. So it was a huge gap in cost. Diabetes also uncontrolled diabetes frequently leads very quickly to chronic kidney disease.
Yep.
And chronic kidney disease is the most expensive condition that a hospital system manages. And that's not considering emergency room or clinic-based treatment. Just from a disease perspective, it is the most expensive thing that they can manage. So from a business standpoint, it behooves them, if you're going to be writing off $1,000, or you're going to be writing off, I don't know. You never go to the emergency room for $7,000. So I don't know why I picked that number, but if you're going to be
depending on what you get done there, and testing,
right.
X-rays,
But
and
if you come in
MRI.
a diabetic crisis, you've easily got a $10,000, through the door preliminary testing.
First, you
Just to
took an
determine
ambulance.
that you're out of control. Yeah.
Yeah.
And then treatment, you often will end up inpatient because you're out of control. And the only way they can bring you into control is through a very regimented medication administration. So what costs $10,000 at the clinic just costs them $70,000, and both are uncompensated. So it didn't take the healthcare systems long to figure out that there was a huge, huge cost benefit to reducing chronic admissions through the emergency department. The other thing that you have to consider with uncontrolled diabetes is it often results in limb amputation, which is a whole nother level of expense. So here I have a regular little case of diabetes that I start with. I have the coaching, I have the management, I see the doctor regularly. So my A1C is under 7. That's one set of costs. Not seeing the doctor, not being able to be in control, not being that under 7 quickly gets you into chronic kidney disease, limb amputation, and usually other compounding chronic conditions. So it's very expensive for a healthcare system. And that's why when we were able to start demonstrating that adding this little ride thing, really helped keep people out of this space and keep them more in this space, the healthcare systems globally listened fast.
And I think to that point, like it doesn't take a lot of $70,000 of patients to provide that ROI in a public transit. I mean, you can buy a personal jet for the cost of that. And growing up, so my husband's grandmother had diabetes, resulted in limb amputation. And when I was in college, would care for her. And I mean, just the amount of time and energy support that came post amputation. I didn't know her when she was going through the amputation, but there's the wound care, the follow-up care, the shadow symptoms, the psychological impact, the loss of mobility because they may be walking and perfectly able to get around. And then the cost goes up. And if you're transporting somebody in an Uber, it might be $20, $40, depending on how far you're going. If you're providing a wheelchair ride to somebody 3 days a week for 20 years, that $20 ride could be $200. And that adds up real at $400 a day just to get to and from the treatment, right? And so I think that cascading effect, that return on investment of keeping people healthy and getting them to that appointment and those appointments to get out ahead of things that they're noticing, whether that be vision changes or, just all the things that happen in life. Amazing.
Right.
Yeah.
It really is. If you look at from a health or a public health perspective, it really is an upstream solution by addressing the transportation needs of a community.
Yeah, 1,000%. And I think that's one of the why it's not talked about very much is because it's not right here. Like you have to use this conversation and focus group and then have conversation after the focus. I mean, it requires really that interdependency or not interdependency, that design thinking about like what's the root cause and what are some of those things. So thank you for sharing that story, Ashley. That was phenomenal. And I think gave a perfect depiction of kind of all the moving pieces in the healthcare, not all, but a lot of moving pieces in the healthcare system and just one use case. And we didn't even talk about cancer. We didn't talk about Parkinson's, all those other things. So thank you.
Maternal child health is another big one.
Yeah, absolutely. So let's talk a little bit about the West Dallas Multipurpose Center, if we can pivot a little bit. So y'all serve a diverse population. I mean, just so many different incredible programs that are lifting up and supporting the community in so many different ways. Do you mind sharing just a little bit about the breadth of programs that you offer? And then what are some of the transportation challenges that you see residents face in accessing programs and services, not only just within the center, but just in the community broadly? I think, folks who are not in this space do not maybe don't get exposure to the breadth of programs that are needed or supported in community centers in this work.
So the West Dallas Multipurpose Center, we operate on kind of a unique paradigm. We are a city-owned property, but we are operated by the Office of Community Care. So we have more of a social service orientation to begin with than, say, a rec center. Essentially, my facility is a giant co-working space because I personally do not believe that I am the be-all, end-all in all program, service, and delivery. So I bring in community partners that have expertise in different spaces to address gaps in service that we've identified in the community. For example, our zip code that we're physically located in has a significant number of people that are reentering the community from being justice involved. And so what we have discovered is, or what we've done is we've located experts in the reentry space, and we've brought them on campus. Some come 1 day a week, some come 4 days a week, and they address the needs of different populations. We have one group that comes that primarily focuses on the first 12 months of reentry. We have another group that comes that focuses on helping people who have been justice involved enter the workforce successfully. We have another group that comes that helps them with, getting registered for SNAP or WIC or Medicaid or something like that. And so we have there are a variety of different issues for people that are reentering the community. We identified a significant population in our community and identified the fact that their needs were not really being met. And so we brought together the people who could meet those needs, and what I contributed to the space or to the conversation was space. We do that. Food access is another big piece of things that I'm interested in. And so we have brought together a variety of different experts in that space. So we've been working on some of the more innovative approaches right now of the produce prescription, the food as medicine movement, providing the agricultural relationship for people. the kind of farm to fork conversation. We do cooking and nutrition classes. We also just do general access to food items, and so we have learned, or as I learn of gaps in services, I assemble a group of organizations that can deliver programs and services to try and close that gap. So transportation is a big one, and it sort of, and it's the little to the big piece of the conversation about transportation. So last year we realized that from my front door, which is ADA accessible, from my front door to the main street's bus shelter, you had to go down the road to get to the bus shelter because we had a light pole in the middle of the sidewalk. And there was no way that you could get your wheelchair, scooter, or walker around that light pole. So it took me a couple of years. I guess it was about 3 years ago that I noticed it. So it took me a couple of years to get all the people who needed to talk about getting the light pole out of the sidewalk thoroughfare to move it. And so, we addressed.
Yeah. I mean, you think about it, right? Like we can send rockets to outer space in the time that it takes to move a sidewalk.
Absolutely.
Like,
Absolutely.
That's the thing that I think a lot of folks just do not, maybe don't hear and know. Like, there is so much regulation and so many different dimensions to the sidewalk, let alone the bus stop, let alone.
Some of it is just awareness.
Yeah.
I needed to talk to 20 people. Right. I had to talk to 20 people to figure out how to get the light pole moved like 3 feet over, off of the sidewalk.
Right.
And so that was, and it required, there were a lot of people. I was like, well, why does stormwater have anything to do with this conversation? Well, it turns out if you put the light pole over here, that it's too close to the storm drain and it's water and it's electricity. And and I'm like, well, who would have thought that? So there were people involved that you would have never thought to think were involved.
Right.
So we address transportation, or I'm engaged with the transportation conversation from that level, but I'm also engaged in, food banks that do drive-through. How are you going to do that if you have no transportation? Because the Uber man does not want to sit in the drive-through line with you. He wants to drop you off and move to the next call. He's not interested in drive-through activity. So we had to figure out people who don't have transportation, how do we deliver this program or service that we're delivering in a drive-through format to those who don't have transportation? So that's kind of the high level of that. Well, the low level of that is, have you ever thought about how you're going to package the donated produce for somebody who has to ride the bus?
Right.
So we had to buy different bags that had handles on them that were more durable so that they could get from the distribution to their home without their produce going all over the ground.
Right.
So, we look at kind of the 50,000 foot level of food access. There's no produce in this community. We're in a food desert. It presents a challenge and a barrier for community members. But then at the end of the day, we better buy the right bags to put this donated produce in so people can get it home, And then you add the element of the fact that we know that one of the barriers to consumption of donated food is awareness and ability and skill set. So here I'm going to give you a butternut squash and I'm going to send you home with it, and I'm putting it in the right bag so you're going to make it to your front door with it. And guess what? You don't know how to cook a butternut squash. So now I have to figure out how to offer a class for you to learn how to cook the butternut squash. And I have to figure out, can you ride the bus back to it? Are you going to ride the bus back to it? Does the bus run at the time that I have the kitchen available to teach the class? Oh, you work till 7, but we want to offer this class at 7:30 and 30 minutes is not enough time to ride the bus. So there's once you start looking at the first question or the problem statement, you often end up with all of these tentacles of conversation that may or may not have anything to do with transportation. But at the end of the day, transportation becomes the deciding factor.
Yeah. Yeah. It's that, you talk about pulling the thread and things start to unravel. And I think that's the conversation around mobility, right? Like,
absolutely.
You just outlined 15 different places where that challenge breaks down,
Right.
whether that be time of day of week, mode, carrying the bags, the distance from the bus stop to the location where the food is. I remember talking to a food bank that just built a beautiful new facility in Corpus Christi, Texas. It was like half a mile from the closest bus stop because that's where they could find the affordable real estate to build it. And it's like they got to the end of it and they're like, oh. And then on top of it, the bus will only let you take 3 bags, and they were distributing, 40 pounds worth of food. Well, 40 pounds worth of food in 3 bags, while you might be able to find those bags that will carry that, depending on your health, your, condition, so schlepping 40 pounds, half a mile, if you're healthy is a lot, and let alone if you have struggling with, bad back, hip replacement, knee replacement, or you've had a long day, all the things. That's
absolutely.
A factor. And then not to mention keeping things cold, right? Like whether that be insulin or whether that be milk or ice cream, there's so many areas where, it's just a ride. Yeah, but it's literally, it doesn't matter how good all the other programs are if you can't get there or get home.
Right. And I think that's one of the things that I appreciate so much about the solutions that Phoenix Mobility has been looking at is they're multidimensional, multifaceted. Because I could say, oh, okay, Dart, I need you to run this bus and have it stop at my place at whatever time so I can have this class. And then I find out, well, nobody can pay for the bus ride to come to my place at that time.
Yep.
So I think it's really important that we continue to have these conversations as organizations and as boards to really think about the depth and the expansiveness of all of the social determinants of health. But I think we need to appreciate the fact that transportation needs to have its own piece of the pie because it's its own issue.
Yeah, 1,000%. I'll never forget, we were talking with a health insurer and they said they came to the realization that it doesn't matter how good the doctors are if they cannot get there. And in this particular community, they had some of the best childhood care and top-notch, pediatric medicine facilities in the world. And they had some of the highest infant mortality rates surrounding the local community hospital. And they're going, WTF, what is happening? And it came down to, the transportation barriers, the language barriers, the bus stops were too close to the road. And so if you're holding an infant in a carrier and you've got a toddler trying to get on the bus stop to get to, you're worried about their safety, and don't even get started with the weather. Like if you're standing outside and it's cold out or too hot out, there's all these factors that just have to be acknowledged for care to be delivered, food to be consumed, employment to happen, education. So, all right. So we've waxed prolific on why it is important and how it can all go wrong.
Yes,
Ashley, do you
yes.
have a story you can share on a positive note where you saw transportation was provided for an individual or a family and you saw the difference? Like you saw like, okay, here's the pre-state and the post-state, and what did that look like? And what was the difference?
Sure. So I can speak from actually kind of an aggregated perspective relative to what the work we did in South Dallas. So it took us a long time to get to the go. And then once we got to the go, it took us a little while to get going. But once we were underway, the impact was pretty significant in the community. And by that, I mean, we not only had individual stories of impact, we heard from the family that, could now get dialysis treatment because she had to go 3 days a week and people worked. And so when we added, the service of the Go Link, because Granny would not ride the paratransit, because she was still mobile. So we got her on the Go Link and we were able to get, there was a little bit of funding. So we were able to subsidize a little bit. DART came through for us with doing discounted passes for people that lived in income driven housing.
Yep.
And so we were able to get her on the Go Link 3 days a week to go get her dialysis.
Wow.
And bring her dialysis, bring her chronic kidney disease into control just by moving that one lever.
Yep.
That same family, we were able to, this is where I learned about the Go Link, obviously not wanting to sit in the drive-through line to get their produce.
Yeah.
So we were then able to help that family learn how to use the scheduling app that DART has to schedule their drop-off and their pickup. Yeah. So that they could go get their produce and then get picked back up by the next one without having to sit there for an hour or 2 hours or whatever. So we saw huge impact on the individual level by making the Go Link more accessible, more affordable. We had to work out I only have $5. How can I put that on my card? I don't have a bank account, those kind of things. There were a lot of logistical pieces that we had to look at.
Sure.
But at the end of the day, what we did was really fairly simplistic, but it was transformational. Yep. We bought 300 tap cards and we loaded every tap card with $12, yep, which would get them basically four Go Link rides. And we said, okay, here's your card. It's got money on it. You can go, come, and figure out how this works for you. And so what we did was we took the risk away from community members and their limited dollars and mm-hmm. gave them a chance to kind of play out with the Go Link. Our numbers shot up by 200% in a month.
Whoa.
The DART people were like, well, what did you do? And we're like, we gave out free tap cards.
Yep.
And so, then we had to circle back because then if you receive SNAP, you got a discounted pass. So your mm-hmm. $12 would go farther.
Yep.
We had to register your card to you. Mm-hmm. But we didn't start there. We started just with, here's a card, it's got $12. Go try out this Go Link thing.
Yep.
So the scary, unknown, high risk situation was quickly diffused.
Educated.
We also know that we were able to address Through the Go Link initiative, we were able to address increased participation in the farmers market at Juanita Craft. We know we were able to increase their new patients, increase their caseload of new people that were able to come to the clinic now. And while they weren't asking the right question on no-shows, we think we were able to impact that also. Because if you were a new person and you were coming on GoLink and you were complying with medical advice, it largely could be traced back to, your ability to get there to be compliant.
Yeah.
So, but yeah, I think that one little initiative made a huge impact on the lives of a significant number of people. But I will tell you, it took us 5 years to get from our first meeting where we said, we have a transportation problem in South Dallas to being able to go back to the dartboard and say, look, this is what we know we've done.
Yeah. And I think, again, that's another amazing story, then a testament that this work requires patience and persistence and flexibility. You can make it happen, but it will not happen in 6 months. It will not happen in 5 years to the degree that you want it to, but it involves consistent effort. And I think one of the things you brought up was the cost of the service and the cost of the car. We used to run a program specifically focused on like mobility in South Carolina. And one of the key things that we started seeing was the cost of the service was the biggest limitation to utilization. And it took us about 2 years to really we thought, if we have the perfect app, people will be able to get where they need to go. And I think that's a fallacy that we see out there all the time about technology will solve it all. I love technology. I think it's the best thing since sliced bread, but it is not the end all be all. And especially when you're looking at serving complex populations who have technology complications, income complications, language barriers, all those kind of things. But the cost, the minute we wrote a grant to the federal government and said, can we provide no cost access to healthcare for partners of our health systems? And it was a game changer. We saw the ridership grow up, we saw the numbers go up, and we're still running that program today. But it took 3 years to go from we want to address this transportation challenge to getting the right people at the table, building those partnerships, writing the grants, all of those things. And now hundreds of people every week are able to get where they need to go to care. But it didn't happen overnight. And it required a lot of effort. And the cost, even if, people take for granted, it's just $3. You can't afford $3 or you can't afford $1. I mean, we ran a program where people had to buy their transportation. They spent the last penny in their bank account. And some of these participants were feeding families of 5-6 kids, and they spent their last dime on an Uber. And when you play that out and you think, what did that make a difference in her ability or their ability to feed their families? Because they, in that decision, right? 41% is what Feeding America indicated that transportation was a root cause of hunger. Do I put gas in the car or buy a bus pass, or do I buy groceries? Or do I get the milk and the produce and the more expensive items that I know are healthier? Or I get what's cheap and I can buy in mass quantity because I've also got to buy these other things. You can only stretch $1 so many ways. So, amen.
Yes. Well, and I think I think people forget the risk. The risk in and of itself is a factor. I'm not going to risk my last $5 on broccolini when I don't know if my family's going to eat it.
Right.
I'm not going to risk my last $5 on GoLink if I don't know it's going to work.
Absolutely.
What if I get stranded? What if they don't come on time or they're not nice to me, or the bus isn't clean, or whatever doesn't work for them. What happens if? And I think that's a question that leaders fail to ask when they don't include the people you're trying to support at the table for multiple conversations.
Yeah.
What I found, especially with South Dallas, is North Dallas, which is more affluent, has lots of research entities, has lots of money, comes to South Dallas to implement their programs. They're going to come fix what's wrong with South Dallas. Well, the problem with that is they've sat in North Dallas thinking up the solution to a problem that they've not even determined anybody has in South Dallas.
Right.
And so what we learned was, okay, great. Yeah. The data says that a family can bear 30% of their total income applied towards transportation. All right, well, that's wonderful. But what if their housing costs them 70% of their income? What if one of those numbers is off whack? Well, then I don't have 30% to contribute to transportation if I plan on serving anybody at my house a meal.
Right.
And so that's one of the things that, we get a little hasty sometimes from a program logistics standpoint. And we say, well, okay, wait, the data here says you can afford 30% towards transportation. What's the problem?
Right.
Oh, well, your apartment is costing you 70% of your income.
Yeah.
Then it makes sense.
Absolutely. Or the fact if you're living on, like when we were, again, going back to that community in South Carolina, when we were looking at the data, I mean, a single older adult was living on $800 a month, and 30% of $800 a month doesn't go very far. I mean, that's, and if you need more than 4 rides to your name to get to the doctor, church, grocery store, any kind of social supportive need that you have, I mean, forget it if you're diagnosed with cancer and you've got to figure out how to get to 54 chemo and radiation appointments in the next 4 months, right? And you'd make just too much to qualify for Medicaid. And the Medicare and the Medicaid.
Or you haven't expanded. We're in a non-expanded state.
Yes. Or it's
So
not
no Medicaid for you here if you don't have a dependent child.
Wow.
And you only get it for 12 months, even if you do have a child.
Wow.
And that's only since the last legislative session that we went from you have the baby and you get off of Medicaid to we'll give you 12 months because we feel nice and we're going to give you 12 months now. But at the stroke of 12 months, you are no longer insured.
Wow. Well, and then you think about the cascading effects of that. We were talking to somebody and, she had a child and she was unhoused with a child who had a chronic illness. And the cost of care and the challenges and the anxiety, just the address situation brought in. And then to not have any way to care, or, you basically live by emergency room. There's no getting ahead. There's no hope of a cure or getting to those specialists. I want to keep my baby alive as long as I can. And what was so hard to hear was, the chronic condition that the child had was likely a result of the housing that the mother was in when the child was an infant, because it was due to lead poisoning. And so it's so tough and it's so complicated, but that is why it takes great people to do this work and champion this cause. So Ashley, finally, just kind of wrapping up, because I think we've covered all of these things through these really beautiful stories. What advice do you have to give to transportation leaders and community advocates who are looking to kind of work together or work in their communities to improve mobility and health equity?
Well, in my opinion, I think the thing we spend the least amount of time in community work and in advocacy work doing is really building relationships in the community. And that, in my mind, means consistently showing up. It doesn't mean coming on, let me go visit them in January and talk to them. And they've never seen me before. And guess what? They're never going to see me again. It means consistently showing up, in my opinion. That's the best way I can describe it. When we were working on the South Dallas Transportation Initiative, it took us 5 years. But every year of those 5 years, we would call a town hall and say, look, this is what we've done. This is what we've accomplished. This is what we're going to try and do next time. And, it wasn't a big hoopla meeting. We served some food. We invited community leaders. We, the people who came to the last one, we invited them again. Word spread to some other people who came each time. But we felt like that was absolutely essential and I really think we could have done it twice a year, except we didn't really have much to report twice a year. But I think it's important that whatever you ask of people, you go back and tell them what you've learned or what you're going to do, or sorry, your information was a bunch of garbage. We don't want to talk to you anymore. I don't know, but
be transparent.
Just show up and then we disappear. And so I feel like whatever work you want to do from a community or an advocacy perspective, you need to show up consistently to the people that you are working with on that. A lot of people talk about, you need to be, you can even talk about, well, you need to be transparent or you need to be engaged, or, the whole conversation around participatory community research pillars and stuff. At the end of the day, in my experience, if I just consistently show back up and tell people what I'm doing or what I've done with their information that they've provided me, it does a world of good. It's a huge game changer for people to hear, oh, yeah, in January, I told you that the DART, I couldn't get to the DART because there was a light pole in the middle of the sidewalk, and I was having to drive down the road, and the cement truck that also uses that road is going to squish me one day. And, for me to just go back and say, well, I've talked to this group and that group and this group and that group, and, the light pole's still there, but I haven't forgotten about what you told me you needed to be done. And I've done something since we talked. I haven't moved any light poles yet. I haven't resolved the issue, but I'm still working on it, And so after another 6 months, they're like, well, the pole's still there. I'm like, you're right. But now I've talked to this person, and this person, and we're getting close to the pole getting moved. And so I think that is really the cornerstone of being successful in working with community members, is being consistently present.
Yeah, I think that's incredible advice, Ashley. And I think there's a number of different areas, like especially in this transportation space, there's every 5 years or 7 years, you've got to do either a long range plan or a human services coordination plan, or they renamed it something else now that's like 5 letters instead of 3 letters. That is beyond my capacity to remember. But and if you just show up every 3 years and ask for feedback, that is not the same as showing up the first year asking for feedback and then showing up the second year and saying, here's a plan. This is what we did with the data. You'll see in the appendices when we had that community meeting, here's your thoughts and your reflections. And we appreciate you sharing it with us. And here's what our recommendations were. And then the next year saying, hey, look, of the 5 recommendations, we've started on 2 of them. And then the next year, and then because it's crickets. It's like, and then eventually people don't believe you. They don't trust you. And then they quit showing up, period. And the way the government money is structured.
For anyone.
For anybody. Yeah. Because you lose trust. You're like, nobody nothing ever changes. So why the
Right.
hell am I going to show up and take your
Right.
damn survey?
Right.
I got better things to do.
I talked to these other 5 people and I never saw them again. So,
Yep. Yeah, exactly. Exactly. And so I think that is fantastic advice, Ashley. All right. As we wrap up this robust conversation, Ashley, we have some, as I like to call them, rapid fire questions.
yes, ma'am.
In 1 minute or less, the following questions. Mobility equity is
Access.
access, plain and simple. What is one piece of leadership advice that is so great you must share it, or so awful you have to warn us?
Oh, that's a hard one. I would have to say it's that be consistent. Because the first time you make an exception, you have to be prepared to make that exception for everyone. So it's sort of an in or out kind of thing. And I actually articulate it that way. I'm sorry, I cannot make an exception for you because I cannot make an exception for everyone.
Yep. Okay. Last TV show you binged on and loved?
Lincoln Lawyer, and I think it's coming back soon.
Yes.
I really liked it.
Oh, love the Lincoln.
I watched it all in like 2 weeks.
Did you watch the second season yet, or just the first season?
Oh, I watched both seasons. Yep. Knocked them both out.
Third season coming soon. Okay. Favorite concert of all time?
It was a long time ago in a land far away. I went to U2 in Houston.
Okay.
Under the Blood Red Sky.
Wow.
It was a great one. Yes.
That sounds like.
And, interestingly, 100 years ago, Bono was still an advocate. He still did not stay just in his music space.
Yeah. No, I think the work that he's done is at the Red Initiative to HIV and AIDS, and the work that he's done is just phenomenal in bringing awareness and advocating on a global stage. 100%.
Yes.
All right. Last question. What one thing that do you think is significantly under discussed in the transportation industry that not enough people talk about?
Well, that was a hard one for me. I think that it's transportation in general. If you get into the transportation industry and conversation, there's lots of robust conversations. But the pathway into transportation conversations is small. There's a lot of people that don't know what they don't know about transportation until they're in the middle of it, knowing it. And so I think I would say that's the biggest thing, is that there's just not a lot of conversation that transportation is a thing with people who aren't transportation professionals.
Yeah. And I think it's like, we were talking this morning to a woman who owns a business. She's been in the transportation space 7 years, potentially operating without the proper insurance, because it's so nuanced and it's so specific and it's so detailed and all these kind of things. And it's like, you got to know the guy to know the guy. Once in a while, you got to know the gal that knows the gal. But it's like, it's very nuanced. And even though
Very
there's
much so.
maybe 20,000 people in this kind of transportation space, I would say, in hardcore, that's still, when you think about the 365 million people in the US, that's a small number. And they have conversations with lots of acronyms that, have multiple acronyms behind the acronyms. But yeah, exactly. But having and being a part of that conversation and knowing if you're in the right room or not is huge. Because I know a lot of people who go to these meetings with Federal Highway or these programs that are focusing on roads and bridges and infrastructure, thinking that they're actually there to talk about the transit issues in their community. Or, and it's like, well, That's not that meeting. That's another meeting. But it is a transportation meeting, so at least you're there. But sometimes the folks on the highway side don't even know the folks on the transit side because the highway side is so massive. So especially
It's so
in Texas,
technical.
whew,
And it's so
yeah,
technical. It's very
absolutely.
technical. You know, I've been in multiple meetings where we've talked about concrete density versus asphalt versus what goes under the concrete and asphalt and
Yes.
stuff. And I'm like, when are we going to talk about people riding on the road? You know, I'm like, I don't know anything about asphalt and cement and layers of
Oh
cement
my gosh.
and
Oh,
ripples on the cement, you
yes, the
know.
rumble
When do
strip.
we talk about people getting in some sort of vehicle on your
Yeah.
road? And they're like, what?
That's not this
You
meeting. We
know,
were
and
about that.
that's and I think that's one of the examples of even within the transportation industry, the cement engineers do not know anything that the bus drivers know,
No.
you know, nor do they have an interest or a forum for exchanging information. You know,
Yeah.
the there's no opportunity for the bus driver to tell the cement engineer that, you know, people complain less when we're on 4 feet of concrete versus when we're on asphalt. And the public works people aren't talking to the street engineers to say, well, your asphalt makes more potholes if
Yeah.
trucks drive over them. And this is largely a truck route or whatever. So
Yeah.
I think that is a huge opportunity is to suck in the transportation conversations so that people over here with the technical expertise are over here talking to the people with the front lines experience. But I also think that we need to open a door so people kind of get into the transportation discussion who didn't know they needed to be in transportation discussions.
Yeah, absolutely. Well said. Thank you, Ashley,
You're
for your
welcome.
time, for joining us today, sharing all this impressive information and knowledge. And you knocked the socks off. So your bio
thank you.
lived up. So thank you so much for your
Wonderful. Well, thank you for having me. I appreciate it. I enjoyed visiting with you about this. I mean, I think we don't talk about it enough. And I think we don't talk about it in enough different contexts. And,
Yeah.
you know, to your point, I think that sometimes we talk about what we're there to talk about and we forget this is an opportunity to create a conversation that doesn't exist now.
Right. Absolutely. Well, hopefully through the Phoenix Insider, Ashley, your words will reach more folks in this space and encourage them to invite others. So thank you so much for joining us today.
Thank you. Thank you.
Thanks for joining us on the Phoenix Insider, where we explore the road to mobility equity together. Don't forget to subscribe and share this episode with your network to keep the conversation going. Together, we can break down transportation barriers and create lasting change. Visit phoenix.org to find out how you can help improve access for everyone. We'll catch you next time on the Phoenix Insider as we continue driving forward toward a more equitable future.